everyone, and welcome to our lesson on pulmonary embolisms in the emergency department. So there's nothing new here, guys. We know that a pulmonary embolism, or PE, can be lethal. It's a life-threatening condition, but if we know how to recognize the signs and symptoms, we can really work to treat it before it's too late. First things first, what is a PE? Well, a pulmonary embolism happens when something occludes one of the pulmonary vessels. Usually it's a venous thrombus that kind of breaks off and travels through the vessels, through the right side of the heart, and right into the pulmonary circulation. Now, these thrombi can come from anywhere, but they most commonly start as like a DVT or deep vein thrombosis in the lower extremities, kind of like this one over here. And kind of breaks off and goes all the way up. So we always worry about risk factors for DVTs and PEs, and these can include any incidence of a previous deep vein thrombosis or DVT, any sort of surgeries in the last 4 weeks, use of estrogen replacements, any active or metastatic cancer, and basically that's caused by a thrombus of the tumor actually breaking off, which, yeah, that's not pleasant. Any recent travel, like, I don't know, if you flew from Hawaii to New York, first of all, you'd be really awesome. But if you sat down for too long, the immobility factor for DVTs comes in. IV drug use is a risk factor, and unfortunately, as we age, we become more at risk for DVTs and PEs. Now, these patients, while they can exhibit symptoms that the problem is they steer us in any number of directions, but they do have a few very telling signs that kind of can alert us towards a pulmonary embolism. You know, many times the symptoms are nonspecific. They can have trouble breathing, rapid breathing, and maybe a little of that red tinge to the sputum. They have sudden onset of pleuritic chest pain. So basically, it hurts to breathe. So let's see, what happens when you can't breathe and it hurts every time you take a breath? Well, you're going to get anxious. And when you get anxious, what's going to happen? Well, your heart rate's going to go up, right? If we suspect a DVT, if we suspect a PE, we want to look for those signs of a deep vein thrombosis, like the leg swelling and that pain behind the knee. There can also be some atypical signs, but if we focus too much on those, it can actually distract us from the main issue. We want to diagnose. So to do that, we're going to need some tests, obviously. Chest x-ray, it's a no-brainer. You want to get a line in and get somebody to get that ABG because you want to see if they're in respiratory acidosis. Acidosis. Wow, I know what I meant. When we get the labs, we want to run a D-dimer. Now, here's the interesting thing about the D-dimer. It's usually done to determine the possible presence of a PE. Usually if it's below 500, then you're safe. And you can go about your business. Over 500 is where it gets tricky because it doesn't mean that a PE is definitive, but it does warrant further testing, like a CAT scan or an MRI or an MRA to further, establish a diagnosis. You're also going to want to get an ultrasound of the leg to see if there are any signs of that DVT kind of still lurking around. We're going to get a 12-lead EKG, and that's basically to rule out an MI, a myocardial infarction, or any other cardiac abnormalities. Now, once the diagnosis of a PE has been confirmed, we got to treat it. So, come on, always start with the basics, right? Get some oxygen on them and get a line in. We also want to keep a close eye on the vital signs, especially the oxygen saturation, and if you have it, capnography, get that CO2 level. In order to prevent further formation of any blood clots or enlarging that current blockage in the pulmonary vessels, we're going to start them on IV heparin therapy. When we start that, there are very specific weight-based formulas for heparin therapy, and hopefully your facility has them written down somewhere. If not, best bet, give the pharmacy a call, and they should be able to help you out. Now, if the blockage is so severe that it needs like immediate removal, there is the possibility of actually using that clot buster, the IV TPA, the tissue plasminogen activator. If we need something more invasive, well, we're going to send them to the cath lab, our good old friends at the cath lab. And they can go up there and have that angiogram, and actually they can do a clot retrieval in the cath lab, which is pretty cool if you get to see that. So as with everything, guys, we need to use our clinical judgment here to determine if this is a pulmonary embolism or something else. If it is a PE, we know that oxygenation is the key as the lungs are getting cut off from the blood supply. And like anything in the emergency department, we need to prioritize in order to treat properly. Don't go getting an EKG before getting them some oxygen. Know what should happen first, guys. A few key points. We need to remember the risk factors, right? The how and the why, as it's really going to help us kind of piece together our diagnosis. We need to know the signs and symptoms, and we need to know what's going to steer us towards a PE and what could be something else, right? What isn't a PE? We need to know basic treatments and more advanced ones. We need to know if it's heparin or if they go to the cath lab. We need to know if these patients can stay in the ED or not, right? And if we can, if you have time, we need to educate our patients about DVTs, about immobility, smoking cessation, things like that, to prevent those DVTs in the future. So thank you for joining us, guys, for this quick lesson on pulmonary embolisms. Please check out all our other emergency medicine lessons here on NRSNG. And as always, happy nursing.